Thank you so much for joining me for tonight's seminar. So I'm Jenna Friedenthal, and I am a reproductive endocrinologist and infertility specialist, and I'm a double board certified OBGYN. I am a specialist in the diagnosis and management of reproductive disorders, mainly infertility, as well as fertility preservation and egg and embryo freezing. So just for a little bit of background about me, so I completed my undergraduate education at Yale University. I then completed my medical degree from the Albert Einstein College of Medicine with distinction in research. I then completed my residency training in OBGYN from New York University. And finally, I completed my subspecialty training in reproductive endocrinology and infertility right here at RMA of New York in affiliation with Mount Sinai. And this is where I've been invited to stay on as faculty, and that's how I'm here today. So I'm really, really excited to talk to you about all things fertility and fertility preservation, namely egg freezing. And so it's okay with everybody. I prepared a few slides. I think it's a good place to start first to just talk about the basics of fertility, what it takes to make a baby, what to expect at your first visit with an REI like me, and then the diagnostic testing that we're going to do. And finally, all the info on fertility preservation, namely egg and embryo freezing. But I'm going to make sure to leave time for questions. For anybody who has questions, feel free to pop them into the Q&A as they come up, and then I will go through everything in terms of all the Q&A when I'm done with the slides, if that's okay. So I'm going to share my screen now, and we can get started. So what does it take to make a baby? So there's 4 basic ingredients, as I like to say it. And so really what you need is, number 1, a uterus that is structurally functional, that is normal, that can house and sustain a pregnancy. Number 2, you need fallopian tubes that are open and without any disease, because that's actually where fertilization occurs in spontaneous conception, is in the fallopian tubes. Number 3, you need sperm of sufficient quality and quantity to fertilize an egg. And number 4, you need ovaries that are ovulating in a regular, predictable way, a healthy, genetically normal egg. And so what should you expect at your first visit? Well, whether you are a patient that's trying to conceive or you're somebody who is interested in egg freezing or embryo freezing, it ultimately should actually be a very similar experience no matter what. Because what we're going through at the initial consult is your complete history, your family history, any medical problems, surgeries in the past, medications that you're taking, allergies, anything that might affect either your reproductive health, your ability to conceive, or our ability to perform an egg freezing cycle if that's what you're looking to do. Then we perform an exam, and what that exam involves is an ultrasound, an exam of the blood via hormone testing. So with the ultrasound, we first look at the uterus. We want to make sure that we know if there is anything structurally going on within the uterus that would need to be addressed surgically or removed that may be associated with future pregnancy loss, infertility, or things like a fibroid, for example, because, for example, if someone has a very large fibroid, which is just a growth, it's a benign growth of the muscle wall of the uterus, sometimes if it is large enough, it can actually make the egg retrieval challenging. And so we always want to know about challenges up front so that we can then plan accordingly and optimize our chances for success. So that's looking at the uterus. Then we look at the ovaries. And so what we are looking at the ovaries is for any abnormal cysts or structures that could affect your reproduction. We also then do a count of the number of follicles that we see in each ovary, and we call that the antral follicle count. That gives us a sense right away of your ovarian age. Am I seeing the number of follicles that I expect to see for someone your age? Am I seeing more or am I seeing less? And I should say, I use the phrase follicle and egg interchangeably. Eggs are microscopic, so we can't see eggs when we look on ultrasound, but we can see follicles, and follicles are just the fluid bubbles in which eggs grow. So essentially, we can use follicles as a surrogate marker for eggs when we're looking on ultrasound. And that's what we're doing a count of in that antral follicle count. And that's what gives us the beginnings of the sense of your ovarian age, your ovarian reserve, so to speak. Like I say, we then also get blood work looking at all of the basic hormones of reproduction. including things like your thyroid hormone, prolactin levels, FSH, LH, estrogen levels, and then something called the AMH, or anti-Mullerian hormone. So AMH is a hormone that's actually made by those small follicles. And so you can imagine the more follicles that you have left, the higher the AMH. The fewer follicles you have left, or the fewer eggs remaining, the lower the AMH. Now, I think it is a subtle, but it is a very important point. All of the testing that I've talked about so far, the ultrasound, the blood work, this is quantitative testing about the number of eggs that you have remaining. But none of this is evaluating egg quality. And I want to say this out loud very clearly for the people in the back. There is no test for egg quality, really. The biggest test, of course, is when someone decides that they want to try to get pregnant, is that they, remove whatever contraception they've been using, and we see how easily or not easily they can conceive. And I just mentioned this because I commonly see patients who come to me for consult because their AMH level was drawn with their OBGYN and it's maybe lower than expected. And they're worried, does that mean that I am infertile? And the answer is no, that by definition does not mean that you are infertile, because we've followed women that were ovulating regularly who are trying to get pregnant, and we've looked at their AMH levels to see if there was any relationship. And there's not. And it makes sense that there is not, because AMH does not reflect egg quality. So whether your AMH is 2, 1, 0.1, as long as you are ovulating regularly, when the time comes that you do want to try to get pregnant, you have no reason to assume that your ability to get pregnant with that egg is any worse off than anybody else with a higher AMH or higher ovarian reserve. That being said, women with a lower AMH will be starting out at a lower AMH when they are trying to conceive. And for some women with a critically low AMH, it may mean that they may end up entering menopause a little bit younger than other people in their age group with a higher AMH. And so for that reason, it can be helpful to know, because it may suggest that we should proceed with fertility preservation sooner rather than later, while your ovarian reserve, while your ovaries are amenable to retrieving follicles or eggs that we can freeze for the future. So we've gone through all the testing that would happen at your first visit. If you are trying to conceive, there are 2 other tests we generally recommend. The first, of course, is the semen analysis, and the second is called an HSG, which stands for hysterosalpingogram. It's a test to make sure that your fallopian tubes are open and without any disease. But now let's focus on the actual egg freezing process, because that's really why we're here, right? So why freeze your eggs? I think that's the most important question to answer tonight. And so eggs are like a box of chocolate, right? Not to quote Forrest Gump and admit my age, but what we know is that over time, there are fewer and fewer chocolates. So aging affects egg quantity, but those chocolates also go bad, meaning that there is also a diminution in egg quality. So aging and the passage of time affects both egg quantity and egg quality. Thinking about quantity, I think it's important to start by reminding everybody the reality of reproductive aging. So the maximum number of eggs that we will ever have as people with ovaries is actually before we're even born. We have the maximum number of eggs when we're approximately 20 weeks old, still in utero, still fetuses. And that's when we have about 6 to 7 million eggs. By the time we're born, we've lost 80% of those eggs, and we're born with about 1 to 2 million eggs. By the time we hit puberty, this number has dropped significantly to only about 350,000 eggs, give or take. And we only ovulate about 400 to 500 eggs. So by the time a woman reaches 30, she's lost 87% of her eggs and 97% by age 40. And nothing, not pregnancy, not birth control use, nothing aside from fertility preservation can stop this process or slow this process down. And like I said, not only does our egg quantity decline with age, but unfortunately, so does the quality. Over time, even if pregnancy occurs, we have higher chances of miscarriage, particularly as we approach our late 30s to early 40s. Age 35 is relevant not because a normal pregnancy is impossible at this point, despite what you may read, but it's more because the slope of this curve, as you can see, really starts to change, and your risk of miscarriage really starts to go up significantly. And so this is another way of looking at the same data. And so this is a figure taken from a study looking at over 15,000 couples that underwent IVF to get pregnant. Again, the reason they're a good population to study is because with IVF, we can actually test the embryos that have been created via something called PGT, pre-implantation genetic testing. And that allows us to know for a person who has embryos in the bank, which embryos are chromosomally normal or not. And again, you can see on the x-axis is female age. On the y-axis is the proportion of embryos in each of these age groups that are chromosomally abnormal. We call that aneuploid. Will not lead to a healthy live birth. And so I would ignore this uptick here when this has been repeated. It's really pretty level, and then it goes up exponentially here. And so look, on the one hand, again, it's not like you hit age 35 and this immediately jumps to 100% abnormal. I think that's why we all know women in their mid-30s that can get pregnant on their own. But what this does show you is that the slope of the curve changes significantly, such that when you're 35 years old, we expect about 35% of your embryos to be abnormal and 65% on average to be healthy. And then by the time you hit 40, these numbers have really changed, such that by the time you hit 40, that 60 to 65% of your embryos are abnormal. And so that ratio very quickly flips on its head in the wrong direction, so to speak. Hopefully this is making sense. And if there are questions so far, keep posting them into the Q&A section and I will get them as soon as I'm done with our slides. So now that we've talked about why to freeze your eggs, I think it's important to understand both how egg freezing works and fertility testing works. And so I think to do that, it might actually be helpful to start with a quick overview of just the normal menstrual cycle, because it is through our understanding of a normal menstrual cycle that we know how to interpret the fertility test and how to take advantage of the menstrual cycle for egg freezing. And so at the beginning of your menstrual cycle, your ovaries will release a certain number of follicles into the visible area of the ovary. And again, I use the phrase follicle and egg interchangeably. And so these are ovaries on ultrasound, and not to overshare on this webinar, but these are actually my ovaries. Yes, I have done ovarian stimulation for embryo freezing. So I'm happy to speak to what that process is like. But this is just showing things on a little bit more of a personal level. And again, you can see these dark circles are follicles. So in the beginning of your menstrual cycle, your ovaries release a certain number of these follicles every month. And from there, your brain sends signals to your ovaries via hormones to pick one of those follicles to be the dominant follicle of the month, the winner, so to speak. All the other follicles that were released then just die off on their own. That one follicle ovulates its egg, and if sperm were present and the stars align, right, that egg fertilizes and makes its way to your uterus and you become pregnant. If not, that egg also dies off and the whole cycle resets about 2 weeks later. So that's the menstrual cycle. Now, why is this important to know for egg freezing? So that's how egg freezing works. With egg freezing, all we're doing is giving you more of the hormones that your brain is already making, so that instead of these small follicles dying off on their own, while the one big follicle gets chosen for ovulation, they are all growing nice, big, healthy, mature eggs that instead of ovulating, we retrieve at the time of an egg retrieval and we then freeze. And so hopefully this is all making sense so far in terms of how we're taking advantage of what's actually happening in a menstrual cycle to freeze your eggs for future use. So now that we've gone through why to freeze your eggs, and we've talked previously about what to do at your initial visit, how egg freezing works in general, I just thought it would be helpful to review what it is like on a day-to-day basis to go through an egg freezing cycle, so you can get a sense of what to expect if you were doing an egg freezing cycle here at RMA. And so looking at the day by day, generally the way it works for most cycles, and I will say this is a general recipe, but part of what we are doing as individuals once we get your testing back is making an individualized recipe or protocol, so to speak, that makes sense for you, your age, your ovarian reserve, and your fertility preservation goals. That being said, most cycles start with the beginning of your period. So you would give us a call on day 1 of your period. You'll say, it's my day 1. We'll say, great. We bring you back usually around day 3 to do another ultrasound and blood work. And if everything looks good, that is actually when you start with the medications. And so what that involves is usually 2 injections a day for about a week and a half. In that time, they're not the scary in the butt intramuscular injections or insulin needles, which are really small. And actually, one of our nurses, we do have an option, can come to your home and mix the meds and inject them for you for an additional fee. So that's extra support that we have for people that are thinking that that might be helpful to them if they were to do, an egg freezing cycle. The rest of the days, so we bring you back day 6, usually day 8, like every 2 to 3 days, to repeat the ultrasound and blood work so that we can monitor how you are responding whether to the medications, whether or not I need to change the dosing, increase or decrease the dosing. Usually by day 11 is when most patients are ready. And that's when we would give you what we call the trigger medications. Again, same type of injection, but it works a little differently. They assist with the final maturation of your eggs so that they're ready for the egg retrieval, which then happens 36 hours later. The day of the egg retrieval itself. Let's talk about that now. So as you can see here, so first of all, everything happens here on site. We have an anesthesiologist. You do go to sleep during your egg retrieval. It's not general anesthesia, so you don't need a tube down your throat to breathe or anything like that. It's all just done through the IV, but you are definitely comfortably asleep before we get started. This is a visual schematic of what's actually happening. The actual retrieval is basically the same as a transvaginal ultrasound that you'll have gotten used to at that point, except number one, you're asleep on retrieval day. You're awake for the other ultrasounds, of course. And number two, on retrieval day, at the end of the ultrasound probe, which you can see depicted here, there will be a small needle that we use with the ultrasound for guidance after you are asleep to make a very small puncture through the vaginal wall. That is how we access and aspirate the fluid from your follicles, and that's how we retrieve your eggs. So everything is done vaginally, nothing is done abdominally. There are no incisions or cuts or anything like that. You'll generally hang out in our recovery room then for about 30 minutes afterwards. We make sure that you're comfortable, that you can eat and drink and go to the bathroom. And from there, you go home. We call you the next day. We let you know how many eggs you have frozen with us. And then you have a follow up with me to talk about those numbers. And we take it from there. I think, speaking of numbers, this is my last slide, and I just wanted to touch on this. I think the most common question people will ask me, certainly in their follow-up, is how many eggs is good enough, right? Like, what's the magic number of eggs frozen? And so this is the best published data that we have on this. And so what you can see on the x-axis is the number of mature oocytes, aka the number of eggs that you have frozen with us. On the y-axis is the probability of having at least one live birth from those eggs, broken down by the age at which you froze your eggs. So for argument's sake, let's just say that you're less than 35 years old. So you would be in this red line here. And so let's just say you had 15 eggs frozen. You can see that would give you about an 85% probability of having at least one live birth. Now, how one feels about the 85%, right, is where the subjectivity comes into play. I think a lot of people would be really happy and comfortable with those numbers, but I think there are other people that would say, how can we get this closer to 100%, knowing that even if you have a million eggs frozen with me, we won't ever be able to 100% guarantee that, you'll have a successful live birth. But that's where we sort of have the conversation of doing another cycle and what that would mean, right? If we had another 15 eggs frozen, now you have 30 eggs frozen, you can see at that age, it's a lot closer to 100%. I think this figure highlights the role of age in successful fertility preservation, because as you can see, freezing your eggs at 35 and under is very different than if you were, for example, 44 years old, to be on the other extreme end. It means that even with 20 eggs frozen at 44 years old, the probability of having a live birth from one of those eggs is only 15%. And so this is the data that starts to open up the conversation for how many eggs a person wants to have frozen before they can kind of move on to the next chapter of their life. So those are all of my slides. And so I think to summarize, we've talked about what to expect at the first visit, why to freeze your eggs, how the process works, and what numbers we're looking for. And so I'm going to stop sharing my screen. And now we can start to go through a little bit of the Q&A, if that works for everybody. So I'm going to start going through. Someone said hi. Hello. Someone here says, can you talk a bit about how a dermoid cyst can impact the egg freezing process? Yes, I absolutely can. So I would say the biggest consideration for somebody who has any kind of cyst, but as an example, a dermoid cyst, is the size and whether we would pose a challenge for us to actually place a needle into the ovary during the egg retrieval. Because with a dermoid in particular, we would never want to erroneously puncture the dermoid. Dermoid cysts have fluid in them that can definitely be like irritating to the abdominal cavity and the pelvis. And so if it were a small dermoid cyst, oftentimes we can just sort of avoid it when we're accessing the ovaries during the egg retrieval process. But if it was a large cyst, meaning like 4 or 5 centimeters or greater, it may be the sort of thing that we would recommend that you have actually removed, just so that we aren't posing any risk of spillage of that fluid of the dermoid cyst into your abdomen while we're doing the egg retrieval, if that makes sense. Sometimes it can also stretch the healthy ovarian tissue, and so that might be another reason that we would suggest removing it, is that we might feel that it's limiting the ability of the ovary to respond to the hormones that we're giving you. But with any cyst and with any surgery, we're always weighing the risks and benefits, because on the other hand, removing a cyst, there's always risk that you're potentially removing viable ovarian tissue. And so part of how we're making that decision is then also looking at the other factors, your age, your AMH, what your follicle count is, to get a sense of what would be better for you to keep the cyst in or take it out. So I hope that answers that question. If not, definitely circle back. Next question was, I've been on birth control pills for many years. When should I get off birth control prior to the egg freezing process? That is an excellent question. For my patients, that all depends on what your ovaries look like when I do my ultrasound with you. So birth control pills can, for a subset of patients, make your ovaries look artificially suppressed. And I say artificial because it's not real. We know that the ovaries, as soon as you're off birth control pills, respond to the hormones and will give you your full potential for how many eggs you might have frozen. But a lot of times that doesn't happen, actually. And I'll see women who have been on birth control pills for decades, and I will do their ultrasound and I will see a beautiful follicle count of, 15, 20 follicles or more. For those patients, you actually don't need to go off the birth control pills before you start your egg freezing cycle. We'll basically keep you on them. And in fact, it makes it a little bit easier for you to schedule it because there's more control and flexibility over when you start. You basically pick a start date with my team, and we stop the birth control pills 2 to 3 days before your medications, and then you get started right away. For that subset of patients in which it does look like the ovaries are kind of artificially suppressed or look really, really quiet, I will tell them basically just to go off the birth control pills for like a month before, and then we would get you started with that next period. You don't really need to wait any longer than that. Okay, the next question was, so someone says their AMH is 0.5 and their doctor advised to use an egg donor. So I would say an AMH of 0.5 in and of itself alone isn't enough information for me to say that you would need to use an egg donor. I have certainly had patients who have had even lower than that of an AMH, and we have absolutely done egg freezing and we've retrieved eggs successfully. But that's just one data point. Other things that would really come into play, I would say the most important thing would be your age, right? Because somebody who is 28 with an AMH of 0.5 is a very different person than someone who's 48 with an AMH of 0.5. Because as I said, what we know is that age affects egg quality and also egg quantity. And so with a 28-year-old, even if your egg count is low, the odds are that each of your eggs are still much more likely to be healthy and viable. And so even if we're only able to retrieve less than 10 eggs, there's a good chance that a majority of those eggs will be healthy. But if you're 48, right, that's a very different circumstance. And so a 48-year-old with an AMH of 0.5, it may be a reasonable conversation to at least consider using an egg donor. So an AMH of 0.5 alone without other information isn't enough to say I would warrant an egg donor, but I would need more data before I could really comment on that. Okay, the next question. Is there a way to assess your fertility to help inform you if you should freeze your eggs or wait till later? If you're not intending to try to become pregnant, i.e. I'm 31, and I'm not sure if I want to become pregnant at 33, 34, or later. So what I will say, and I recognize it's easy for me to say this, but if you are thinking that you want to become pregnant later, there's never a better time to freeze your eggs than right now, because of, by definition, that slide that I showed you where the curve goes up exponentially in terms of odds of chromosomal problems with your eggs. Your eggs will never be as healthy as they are today, forgetting about the quantity, which also declines with time, right? And so on the one hand, there's no great way to assess your fertility in the sense that there's no test for egg quality, but we know by definition that egg quality declines as you get older. We also, in terms of testing that we can do, though, we can test your egg quantity. And so depending on what the ultrasound showed and where your ovarian reserve is, that also may motivate you to freeze your eggs sooner rather than later. But certainly if you're 31 years old and you're thinking that you want to delay childbearing and family building till your mid to late 30s, you're never going to have a better chance of having a successful outcome than if you freeze your eggs sooner rather than later, because by definition, your eggs will never be as healthy as they are today. I hope that that makes sense. If that doesn't, like, let me know and circle back and ask the question again. Okay, the next question. Am I understanding correctly that the process of using hormones to stimulate your follicles does not speed the decline in the overall number of eggs, since they would have been released that cycle anyway? That is exactly right. That is a perfect explanation for why this is not decreasing your overall number of eggs, because all we are doing is taking advantage of what's happening anyway, which is that your ovaries are releasing more than one follicle every month. And the ones that are not chosen to ovulate are just dying off. So all we're doing basically is rescuing follicles that were already released, that were already going to die off, and instead encouraging them to grow those eggs so that we can retrieve them and freeze them. So for better or worse, we can't access your overall number of eggs, even if we wanted to. We're only accessing eggs that were already released and we're going to die off anyway. Hopefully that makes sense. Next question. These are such good questions. Is an oocyte an embryo or an egg? It is an egg, an unfertilized egg. How does the cost vary if during the initial retrieval you don't retrieve the number of eggs that you're comfortable with and want to do additional retrievals? That probably varies center to center, but generally speaking, each egg freezing cycle is its own process and its own procedure with its own costs. Okay, if you have PCOS, how does that affect the quality of your eggs? That's a great question. As a fellow PCOSer, it's something that means a lot to me. What I will say is that historically, there was some literature that was published out there that worried a lot of people, that said that there was an association with PCOS and poor egg quality. I would say that subsequent data that's been published has been counter to that, meaning that we don't really see a significant difference in egg quality in our PCOS patients. And in fact, PCOS patients are excellent candidates for egg freezing and for IVF and for embryo freezing. It's like the one silver lining of having PCOS. Again, I say that as a fellow PCOSer, because you have a lot of follicles that are easily accessible. And so women with PCOS tend to do really well in terms of egg freezing, embryo freezing, and IVF, because we're able to retrieve a lot of follicles, a lot of eggs. And on some level, the more eggs that you start with, the more likely you are to end ultimately with more healthy embryos to be used in the future. I hope that that makes sense. Again, if not, please guys keep circling back and asking questions. Next question was, I started the webinar late. This may have been covered. How many eggs are typically retrieved during one round of egg freezing? It's a great question. I didn't answer that exactly, but I will now. It depends, right? So it depends all on what your ovarian reserve is and what your potential really is. And one of the ways we answer, the main way we answer that question, is with that initial antral follicle count, which gives us a sense of your ovarian reserve, how many eggs you have left in general, but more importantly, also gives us a sense as to how many eggs you might expect to get at your egg retrieval. And so part of that is general. It can be age-based. The older you are, the fewer eggs you have remaining. And so the lower the number of eggs we might expect to get, but can be individualized depending on what your ovarian reserve is. And so it can be as few as 1 or 2, right? And can be as many as 40 or more I've had. It's a very individual thing that we answer when we do that initial ultrasound, or at least start to answer. Okay. Next one says, I'm 34. My mother, grandmother, and aunt all went through menopause in their early 40s. How might this affect me? That's an excellent question. And it does speak to a concern that we know, which is that since people ask me this a lot, how does fertility like run through families? And if my mom had babies in her 40s, does that mean that I'm good? So unfortunately, that's not what it means. Meaning if your mom was very, very fertile, it doesn't mean that you are fertile. Unfortunately, what we do know, though, is that early menopause can be an inherited thing. And especially if you're saying that you have like multiple women in your family that went through menopause early, you may also be at increased risk for going through menopause early. Just for the group, average age of menopause is 51, 52. So early 40s is definitely early and would be considered early menopause. And so if I were you, I would definitely see an REI so that we can start doing at least some basic ovarian reserve testing and see what your ovarian reserve is. And then depending on what your circumstances are, whether you are single, whether you're in a relationship, whether you're at the point that you're ready to build your family or not, knowing where your ovarian reserve is and how close you may or may not be to menopause may help us to dictate what the best proactive course of action should be, whether that's freezing eggs or embryos right now, or whether that's having you try to get pregnant right now sooner rather than later. So not, thinking about moving up your timeline a little bit more than expected, but either way, with this history, I would suggest that you see an REI sooner rather than later to start that up. Okay. Someone asked about PCOS. I think I addressed that, but if there are other specific questions, let me know. What I'll say a little bit more about PCOS, again, not to totally throw this into a PCOS lecture, although I love talking about PCOS, but women with PCOS at baseline tend to have more follicles accessible in their ovaries. And so women with PCOS tend to do really well and get more eggs per cycle than women who don't have PCOS. The double-edged sword of that, though, is that women who have lots of follicles and a high egg count may have more of some of the common side effects that you feel during the egg retrieval than people who have fewer eggs. Most commonly things like bloating, cramping, a little bit of pelvic pressure, and that can last for a couple of days after the retrieval. But otherwise, women with PCOS tend to do quite well with egg freezing and embryo freezing. Okay, does ovarian rejuvenation, PRP, assist patients over 40 if there are no other fertility issues are present? So I just was speaking about this with a patient today. PRP, for those who don't know what that is, has been touted as something to assist with, as I said here, ovarian rejuvenation. So women who are older and we know have poor egg quality or quantity, the idea is that somehow it can help to stimulate production of new healthy eggs. We were all hoping that it would be the, sort of next magic bullet that would help our patients with low ovarian reserve or our older patients. But unfortunately, there have been some randomized trials that have been published recently that show that it doesn't actually significantly change outcomes. And so it is definitely at best considered experimental. It is not something that I would routinely recommend because unfortunately, it doesn't really change the outcomes as far as we're seeing. However, the next question, are there any supplements or vitamins that you can or should take in preparation for egg freezing? It's a great question. So I personally am of the gestalt that less is more, because I think that you're going through enough in the process of egg freezing and doing the right thing with even doing fertility preservation, that anything we can do to make it easier for you is better. There's a lot of stuff you can read on the internet about supplements, but I kind of think of supplements as the Wild West of medicine because they're not FDA regulated. So there is nobody overseeing whether or not what is supposed to be in the supplement is actually in it in the concentration that is claimed, and that there are no additives. There was some recent spot check that showed that there was arsenic in one of the supplements that people were using, and actually a prenatal vitamin. So I always take supplements with a grain of salt. That being said, I would say of all the supplements out there or vitamins, coenzyme Q10 is kind of the most popular one that you'll read about. And there's some data to maybe suggest that coenzyme Q10 can maybe improve egg quality. So of all the supplements out there, that's the one that I say is okay for my patients to take, and is relatively benign and safe too. Okay, can you talk about overstimulation and the effects of going through egg freezing with PCOS? Wow, we have a lot of PCOSers out there. I love that. So what I will say is that the process of ovarian stimulation is by definition hyperstimulation. So what we call this in the medical world, egg freezing, is controlled ovarian hyperstimulation. But I would place emphasis on that first word, controlled. This is supposed to be something done in a controlled fashion where we are monitoring your levels to make sure that it never becomes what I think you're referring to, which is ovarian hyperstimulation syndrome. In modern fertility centers like RMA, clinically significant ovarian hyperstimulation should be exceedingly rare because in modern IVF and egg freezing centers, number one, we're able to use much lower doses than we were able to previously to prevent overstimulation of your eggs to an unsafe level, so to speak. Number two, that's why we're monitoring you very closely. Number three, one of the tricks that we have for preventing significant ovarian hyperstimulation syndrome, or OHSS, is with the trigger medications. Back in the day, 20, 30 years ago, we didn't have the same types of trigger medications available. Now we have trigger medications that clear the body a lot faster, and clearing the body a lot faster means your hormones are coming back down to baseline much, much faster than if you were doing IVF or egg freezing many years ago. So that also prevents significant OHSS. And finally, when people heard or taught, were taught about OHSS or overstimulation, hyperstimulation, it was really in the context of old IVF, in which people were doing what's called fresh transfers, meaning they would stimulate your ovaries, do the egg retrieval, and 3 days later, they would put an embryo back in without giving your ovaries the time to cool down and go back down to baseline. The problem with that was that if it worked and someone got pregnant, pregnancy hormone, HCG, exacerbates hyperstimulation significantly. And so patients were caught in this catch-22 where they were pregnant with a highly desired pregnancy that they didn't want to terminate, but that pregnancy was making them sick with ovarian hyperstimulation syndrome, and there wasn't really anything that we could do about that to treat it. In modern egg freezing and IVF, these are really all non-issues. Now, like I say, women with PCOS may be more likely to experience the very mild effects of hyperstimulation, like bloating and cramping and pelvic pressure. But all of those should be self-limited and resolve on their own once you have the egg retrieval. It is exceedingly rare, thankfully, in any reputable modern egg freezing center or IVF center to have clinically significant overstimulation that would require hospitalization or sort of any further intervention in that way. So I hope that answers that question. If not, keep circling back. Is it true that it's only the age of your frozen eggs that matters and not the age of your body when you later use your frozen eggs? Yes, it is true. That is why egg freezing is amazing and magical, right? Because the odds of pregnancy are the same as the age that you froze your eggs, not the age of your body or your uterus. Your uterus doesn't really age. So if you froze your eggs at 30, whether you use them at 38, 40, 42, the odds of that pregnancy being successful are the same as you were when you were 30 years old. Now, listen, the caveat to that is that being pregnant at 42 is a different question, right? And so by definition, the older you are when you're pregnant, the higher risk it is for things like diabetes of pregnancy and things like that. But the success, the odds of getting you pregnant, is all dependent on the age that you froze your eggs. That's exactly right. The next question, do you follow a natural or medicated cycle? I don't know if that's more for a question geared towards just trying to conceive and not towards fertility preservation, because with fertility preservation, by definition, we are giving you medications to stimulate your ovaries. Okay, on average, how many oocytes are normal on retrieval? I think maybe what you're asking is like if there were, I'm making up numbers. If there were 12 eggs frozen, what proportion of them would you expect to be of the good sort of visual grade that we would freeze them? If that's the question you're asking, it can vary, but I would usually say like upwards of 60 to 80%. So if 12 eggs retrieved, I would hope at least 8 to 10 of them are of that good maturity that they could then be frozen. It's never going to be 100%, right? There's always going to be a couple of immature eggs or degenerated eggs that we can't freeze, but the majority should be healthy and should be able to be frozen. Okay. So I think the next question says my age is 48. I think that's you might have been the person who asked about the AMH of 0.5. And so I think that's why probably your doctor was having that discussion about an egg donor. Can you talk a little bit more about the expected pain during the retrieval process, and would you recommend taking time off? Yeah. What I will say, having also gone through it myself, is that honestly, I would say for me and for most of my patients that have gone through this, it is less involved than you think it will be. You definitely do not need to take time off for the full week and a half. The most common thing to experience during that week and a half, the most of the days, I would say is feeling tired, occasional headaches, occasional breast tenderness. Like I said, right around retrieval day, one of the ways that we kind of start to know that you're ready for the retrieval is that you'll start to feel that bloating, cramping, and maybe some like pelvic fullness. That's just like literally your ovaries getting bigger. And that can last for a couple of days after procedure. Most of my patients do go back to work the next day, actually. But if you needed an extra 2 to 3 days after that to kind of recover, that's also like within the scope of what's normal. But you shouldn't need more than that. And you definitely don't need to take off like the whole egg freezing cycle, like while you're just doing the injections every day. You can definitely work. And in fact, our monitoring appointments start at 7 a.m. so that you can come in, get your blood work done, get your ultrasound, and then go on with the rest of your workday with hopefully as little intrusion into your workday as humanly possible. In terms of the process of storing eggs, so right now our eggs, everything is stored here on site. Eventually we may need to start using like a long-term storage facility for people who are, really not planning on using their gametes, for a long time. But right now everything is stored right here in the 9th floor of RMA where I am sitting. Okay, next question. I was told that for my egg freezing cycle, I would go on a birth control pill when my period starts, and only after that step start with the medication. What is the reason for first taking the birth control pill? It's hard for me to answer that, not knowing your, medical history, your ovarian reserve, your age, other things like that. But the pill can be used in a number of pretty cool ways. For some people who have like a very low ovarian reserve, sometimes what can happen is that your ovaries start recruiting a dominant follicle to ovulate like a lot earlier than expected, which is not what we want to happen for an egg freezing cycle. So for some of those patients, your doctor may want to start you on birth control pills before you actually start the egg freezing process to try to suppress your ovaries from recruiting a follicle early. So that's what may be going on with your physician, but it's worth asking the question to your team. Sometimes we use the birth control pills just for scheduling purposes, right? Like if someone's away on vacation and they want to be able to start right away when they get back, if we keep them on the birth control pills, it keeps their ovaries suppressed so that we can start them right away. So we can use it for practical purposes and sometimes for clinical purposes too. Okay, for a person who is in premenopause at 35 years old, do they have fewer eggs or no eggs? The person has to be looked at. The answer is it depends on what your numbers are. And so you can have diminished ovarian reserve, like a low egg count at 35 years old, but that doesn't necessarily mean that you have no eggs. But there are some women who, even if they may have some eggs in reserve, there's such a critically low number of eggs left that they would not be a candidate for fertility preservation. That question can be answered based on things like your FSH level, your LH level, your AMH level, and then the ultrasound. Do you know egg quality after retrieval when you freeze them, or do you test for aneuploidy before freezing? That's a great question. So unfortunately with eggs, when we're talking about egg freezing and egg quality, and really when we're talking about egg quality, we're talking about the chromosome content of those eggs, right? Speaking to aneuploidy like this person said. Unfortunately with egg freezing, we cannot test, we cannot do that genetic testing. We cannot test for egg quality in that way because an egg is a single cell. So by definition, if we were to biopsy that cell to send it off for chromosome testing, we would be destroying the cell. So one of the things about egg freezing versus embryo freezing, with egg freezing, whether you have 5, 10, a million eggs frozen with me, right? We won't know the chromosome content of those eggs until the time comes that you want to use them. And then yes, what we would do is we would thaw them, fertilize them, grow them into embryos. And at that point, we can biopsy them and see which ones are chromosomally abnormal or not. Okay, next question. How would you characterize a potential risk of delaying egg freezing by 1 to 2 years for 32-year-olds with an AMH of 1.39? Very great question. The answer is tough, right? Because we know that once you hit your early 30s, you're starting to hit the point that you're in a lot of reproductive flux. And the thing that we can't account for are changes in egg quality, because like I just said, we can't screen egg quality. An AMH of 1.39 is sort of technically above what we would call low ovarian reserve. Low or diminished ovarian reserve, one of the markers is when your AMH is less than 1. So you're technically above that with an AMH of 1.39. What I can't know is what's going to happen in 2 years. And there certainly is a possibility in 2 years that you come back, your AMH may be less than 1, which means that you will have a significantly lower number of eggs available. Doesn't mean that you can't do egg freezing at that point. It might mean that you may end up needing to do more than 1 cycle at that point to get an adequate number of eggs where you feel comfortable that you've preserved your fertility. So that's how that may be impacted. Hopefully that makes sense. Okay. I'm under the impression that freezing embryos is more effective than freezing unfertilized eggs. Can you speak to this and the difference in the efficacy between these two? Yes, absolutely. So there are 2 to 3 key differences when we think about egg versus embryo freezing. So the first is just a definition, right? So egg freezing means the eggs are unfertilized. And the biggest benefit to that is the reproductive freedom that comes with that, meaning eggs that are unfertilized belong to nobody but you, and you can use them whenever, however, if ever you like. With embryo freezing, an embryo is an egg that has been fertilized by sperm. So once it's been fertilized, it cannot be unfertilized. It is committing you to that sperm, wherever the sperm source is. There are 2 other differences. So the one difference is what we call the difference in the thaw survival rate. What proportion of the eggs or embryos survive the thaw when the time comes that you want to use them? Now, every center is different, so I can only speak to RMA. At RMA, our egg thaw survival rate is about 90%, meaning of 10 eggs that were frozen, we expect at least 9 of them to survive the thaw, which is great. It's above national average, but it's, you compare that to our embryo thaw survival rate, that's like 98%. It's pretty unusual for an embryo to not survive the thaw. Main reason being that embryos are bigger, so they can just survive freezing and thawing better at 60 to 100 cells than an egg, which is literally 1 cell. The other difference is with embryo freezing, we can and generally routinely do perform PGT, that chromosome testing. And so you have just more information up front of all the eggs that you had retrieved from that cycle, what proportion actually led to embryos that have real viability, so to speak. And again, in a way that with egg freezing, you just don't have that information because we can't do PGT with egg freezing. So that hopefully answers that question. Someone was asking, would I recommend CoQ10? So I hit that before. I'm fine with it. I don't feel strongly about needing to use it because I think the data is pretty ambiguous, but it's a relatively safe supplement, so I'm okay with it. Because it's not FDA regulated, there are no structured dosing regimens. So I really just say go by the brand that you're buying and go with the dosing that they suggest. Okay, next question. Can you repeat AMH testing annually to get a sense of how urgent egg freezing may be for your individual profile, meaning like balancing with delaying for I guess, financial reasons is what it sounds like. You can, you absolutely can. And there may be actually some benefit to that because at least you're getting a sense of what your egg quantity is. I will just reemphasize that it is not telling us anything about egg quality. And so even if over time your egg quantity has remained relatively stable, your egg quality is always declining with each year. So even if you have the same amount of eggs retrieved, the proportion of eggs that would lead to a healthy embryo is going down by definition. Would I recommend omega-3s, folic acid? Yeah, so folic acid for egg freezing, is not strong. It's really not necessary, I'll be honest with you. That's really more for prenatal, so people who are trying to conceive. The amount of folic acid that you would want to use is 400 micrograms. But you don't need to be doing that when you're egg freezing. That's really not necessary. Omega-3s, I feel pretty ambivalent about. That being said, they're not bad for you, and there are plenty of cardiologists that are telling people to use omega-3s in their the daily vitamin regimen just for cardiovascular protection. So I think it's fine to use. It's just I don't think that there's really no data to show that it actually improves egg quality or outcomes from stimulation. Again, it's a supplement, so just go with what is instructed on the bottle because there's no structured dosing. Okay. Next question. Can you say more about testing for chromosomal abnormalities? Is egg testing possible prior to pregnancy or only after? Also, is there a method of freezing that is better? I think we've hopefully touched on this, meaning that we can't test for chromosome issues with the eggs, but once you fertilize the eggs and they become embryos, yes, that's when we can test the chromosomes prior to pregnancy. so that we know before we're putting an embryo in whether it's chromosomally normal or not. Okay, next question. If I go through menopause early, does it still make sense to freeze my eggs? Well, if we've caught your, if we've met with you and we've caught you before you've gone through menopause, 100%, yes, that's the whole purpose of freezing your eggs. So that if, God forbid, you end up entering menopause early and you're not able to conceive on your own, we have those eggs frozen to give you at least a chance at trying to get pregnant on your own. If by the time you come to see us, you've already gone through menopause, then unfortunately, no, we wouldn't be able to freeze your eggs. Do you mind showing the slide again with the number of eggs on one axis and having live birth on the other? Yeah, of course, no problem. Let me share. And so this is that slide. You can feel free to take a screenshot, whatever works for you. And then I'm going to keep going. There's 2 more questions. Is there a recommended amount of eggs to have? The answer to that is actually conveniently right here in this slide. And really depends on the age at which you freeze your eggs. Because as you can see, 20 eggs frozen at age 35 is really, really different than 20 eggs frozen at, let's say, 39, right? At less than 35, having 20 eggs frozen gives you like a 90% probability of having at least one baby from this process. On the other hand, doing this at 39 gives you only a little bit above a 60 to 65% probability of having at least one baby from this process. And so what the recommended amount of eggs to freeze is going to depend on you and your age. Hopefully that answers that question. And then the last, not the last question, actually, we now just have a few more, just kidding. Can you ship frozen eggs in case we move to a different town? Yes, definitely. What I would say is that most of my patients honestly don't end up doing that though, just because they worry about risk of travel and injury during travel. And so when the time comes, we usually just fertilize and grow the eggs into embryos here, and then freeze them here while we're waiting for the PGT results. And then because when it comes to the embryo transfer part of it, which is what you're using the eggs for in the first place, it's actually a lot more straightforward and laid back and hands off. So most of it can actually be done locally. So what my out-of-state patients end up doing, I just had a patient from rural Pennsylvania recently. We thawed her eggs, fertilized them, had everything here on site. She did the ultrasound before the embryo transfer locally in Pennsylvania, and she just came to us the day before the transfer so that we could I could look myself, make sure that the uterus looked good. We did the embryo transfer the next day, and then she went back home and she did all the monitoring of the pregnancy. I just graduated her recently, locally in Pennsylvania. So I would say that's what most patients do, but they're your eggs. So ultimately, if you decide that you want to move them, we can ship them wherever. If I have gone through menopause and have eggs frozen, am I able to get pregnant later? Yes. And that was the beauty of you having frozen your eggs. Obviously, it depends on, how old you were when you froze your eggs, what the quality of those eggs are, et cetera. But it means that you're still in the game, which is great. If you want to have 3 to 4 kids, should you plan to freeze more eggs? The answer is on some level, yes, right? Like on some level, this is one of those moments where more is more. And so, it depends on how many eggs you have frozen in the first place. But all that data that I showed you is for just having one baby. We don't yet have the data published for if you want 2 babies or 3 babies or 4 babies. And so that may be a reason that you'd want to freeze more eggs. Okay, and then the last question, I think, is if you've had a STD, so a sexually transmitted disease that was taken care of, can that affect your egg health? Generally not, actually. When sexually transmitted infections affect your fertility, the place where it tends to affect is actually your fallopian tube. So things like chlamydia and gonorrhea can cause blockage of the fallopian tubes. And that can definitely affect your fertility because if you have blocked tubes, then by definition, the egg and sperm can't meet. And the only way that you would be able to get pregnant would be through IVF. But that doesn't generally affect egg quality, and it doesn't affect your odds of getting pregnant through IVF either. So that's the good news. Okay, I think we've actually managed to hit all the questions. And it's 6:25, so I'll hang out for another couple of minutes in case anybody else has other questions. But otherwise, thank you for such active feedback with the Q&A. I really appreciate it. I hope this was informative. I hope you learned stuff. And if you want to see me or any of our reproductive specialists here at RMA, reach out, call us. Our phone number is 212-756-5777, or you can just go through the website. And I hope to see you then soon. I'll stay on for another couple of minutes, like I said. Yay. You're welcome. Yay, fellow PCOSer. Awesome. Oh, wait, we actually have a couple of other questions. Sweet. Is there different methods of freezing? And is there one that's more recommended than another? It's a great question. The answer is that historically there were two methods of freezing, something called slow freezing versus rapid freezing, which is known as vitrification. Any modern IVF or egg freezing center should be using vitrification because it is a significantly better method. They are much higher success rates, meaning like higher thaw survival rates, higher implantation rates when using embryos. And so that's what we use, of course. But any modern fertility center should be using vitrification for freezing. So make sure you ask about that. Okay. Okay, last question. Do babies born from IVF have higher risk of birth defects? Generally speaking, what all of the more recent publications have shown us is that generally not. Historically, there used to be a concern that there was a slightly higher risk of like cardiac defects, but that in subsequent literature has been debunked and it's not really above the average just general population of birth defects. Okay, one more minute and then it'll officially be 6:30. You're welcome. All right, I'm officially going to log off again. I'm Jenna Friedenthal. Really nice to see all of you who are on here, and thanks for hanging out. And you guys be well, and hopefully I'll see you soon.